Okay, so today we're going to cover just some basics on granulomatous and histiocytic diseases. And I adapted this lecture from the year that I was a Cleveland Clinic fellow. So what is granulomatous inflammation? By definition, we're looking for chronic inflammation, and it's more of a reaction pattern where the predominant cell type is an activated macrophage with a modified epithelial-like or epithelioid appearance. We see granulomas, which is a compact organized collection of mature mononuclear phagocytes. So in every granulomatous inflammation, you're not always going to have a ton of granulomas. You may have just a mix of giant cells and some lymphocytes, histiocytes, maybe some focal neutrophils as well. So not all granulomatous inflammatory patterns are created equal. And you really have to see multiple examples to get an understanding of the variation. So here's a picture of a granuloma. You see this well-defined collection of epithelioid cells. And this is surrounded by a dense lymphocytic rim. And so in this case, this may be a more of a tuberculoid granuloma. You may have to put it in clinical context to really have an understanding of what type of granuloma it may be. But this is just the basic pattern of a granuloma. So you're going to look for these well-defined collections of cells, and they may or may not have lymphocytes surrounding them. Now, if they don't have lymphocytes, then you can think of that as what we call naked granuloma, and that would make you think of sarcoidosis. So just an example of a granuloma picture. So what are the characteristics of an epithelioid macrophage? So epithelioid macrophages typically have pale pink granular cytoplasm with indistinct cell borders, a pale nucleus that is oval or elongated, and they often fuse to form giant cells. So when you're looking at an inflammatory infiltrate, if you identify cells that have more of an oval or elongated nucleus with pale cytoplasm surrounding it as well, then you're probably dealing with some type of histiocyte or macrophage that's activated in the tissue. You're going to look for cytoplasm that does not have any other defining characteristics to make you think that it's another cell type. And so if it's not a lymphocyte, a neutrophil, an eosinophil, if it's not endothelial cells or fibroblasts, and you see it in inflammation, it's probably going to be some type of histiocyte. Now, of course, we can do immunohistochemistry to help prove what cell type that is. And CD68 or CD163 are really common immunohistochemical markers that will actually stain these cells. Let's cover some giant cells here. So what are the different types? I'm sure that you've heard of many of these. If you're a beginner, you may not have heard of some of them. So foreign body giant cells typically contain nuclei that are randomly arranged. Langhans giant cells have nuclei that are arranged more in a horseshoe shape. Teuton giant cells have nuclei arranged in a collarette, and we'll show some pictures of these. They're usually surrounded by lipidized or foamy material. In some entities, for example, like juvenile xanthogranuloma, have a lot of Teuton giant cells, but they may not always. Ringed siderophages are a special type of Teuton giant cell with hemosiderin, and you see this often in a hemosiderotic dermatofibroma. And osteoclast-like giant cells, which of course resemble osteoclasts, which are often multinucleated, and you can see that in giant cell tumor of the tendon sheath. Here's a picture of a Teuton giant cell. So you see this kind of nice circular collarette of nuclei fused together. You'll see these in classic examples of juvenile xanthogranuloma. Langhans giant cell, you can see more of a horseshoe pattern. Now, I will say a caveat to trying to classify these giant cells is that depending on which cut orientation, you may not see the exact pattern. So you really have to kind of look around and get a sense of the average pattern that you're seeing within the giant cells. Foreign body giant cell, this is the most common type of giant cell that I see, and that's because I see a lot of ruptured epidermal cysts. And so when you have granulomatous inflammation in reaction to that ruptured keratin in the surrounding dermis, you have a mixture of lymphocytes and histiocytes, giant cells, foreign body giant cells coming in to absorb that keratin debris, as you can see over here with these little empty cleft-like spaces. You can have cholesterol clefts and or keratin within these giant cells, and surrounding lipid being absorbed from just the cholesterol content associated with the ruptured cyst. And osteoclast-like giant cells, as you can see here, they look similar to bone cells that are involved in remodeling. Obviously, from medical school, you remember osteoclasts are really more involved in absorbing bone material, and so you have a mixture of, they look out of place. They look like they could be osteoclasts, right? But the giant cells take on more of a multinucleated appearance. They're quite large, and the the giant cells don't actually look like any of the other types of giant cells. But this becomes important when you're looking at diagnosis like um, giant cell tumor of the tendon sheath, where you're going to actually look and see if you have a bunch of these giant cells within the tissue. Now, you may not be able to orient it to a tendon sheath, and you may just have some type of osteoclast like giant cell tumor of soft tissue as well. So really take it into context. But the purpose of these slides are just to orient you to the basic types of giant cells. Moving on to granulomas. So there are many different types of granulomas. You have sarcoidal granulomas, necrobiotic granulomas, tuberculoid granulomas, suppurative granulomas, foreign body granulomas, and miscellaneous granulomas. So we will hit some of the highlights here. Let's start off with sarcoidosis. So what is sarcoidosis? It's a chronic granulomatous disease of unknown etiology. It's a diagnosis of exclusion. We often see it in African American or Black patients, much more than we see in Caucasian patients. However, I've seen the diagnosis in all different races and ethnicities and Fitzpatrick skin types. The clinical features include up to 1/4 of the patients with cutaneous findings. The cutaneous findings are present in 1/4 of patients with systemic sarcoidosis. So just because they have systemic sarcoidosis doesn't always mean they're going to have cutaneous findings. And it's important to note that cutaneous sarcoidosis can occur in the absence of systemic disease, also in about 1/4 of the patients. So you don't always have both cutaneous and systemic findings. It's important that if you have any hint of cutaneous or systemic findings, that you should look for one or the other to really gain a complete picture. But I will say that most of the cases of sarcoidosis that I've seen were identified, and they were through a skin biopsy, obviously, because I'm a dermatologist. And then we later found that there were other joint involvement, eye involvement, lung involvement. And so a dermatologist may be the first one to diagnose this because of the skin lesions. If something's happening internally, then, and the patient doesn't have very good follow-up, then these cases can go easily missed. So dermatologists are often the first specialists to biopsy these, obviously, but to help make the diagnosis. So here you can see just some nondescript papules coalescing into plaques and nodules on the back of the neck. Sarcoidosis is a great mimicker of anything and everything in dermatology. And in fact, you can have morphologic presentations that mimic almost any other type of dermatosis in sarcoidosis. So, hypopigmented sarcoidosis, you could think that you're dealing with some type of vitiligo or hypopigmented MF, and you actually biopsy and see sarcoidal granulomas causing the overlying hypopigmentation, even though it didn't feel like there was much substance there. There's just a ton of morphologic variation with sarcoidosis. And so when you're developing your differential diagnosis for any entity, it's never wrong to say sarcoidosis is on your differential. Just a cartoon to kind of remind us of where sarcoidosis can affect the human body. So if it affects the nose, that's called lupus pernio. You have painful skin and sores around the nose, on the face. Obviously, in dermatology, there's a lot of confusion when you use the word lupus and you're talking about sarcoidosis, but just remember, historically, this was called lupus pernio. Unfortunately, you can have complications involving any organ from head to toe. So brain, ocular, salivary glands, lymph nodes, heart complications, granulomas within all tissues, obviously liver enlargement, spleen enlargement. There are some variations where you can have erythema nodosum, which is a septal paniculitis associated with the sarcoidal state, and you may not actually see any sarcoidosis within those erythema nodosum, lesions. Rather, you're just going to see a septal paniculitis. And so we will cover paniculitis in different lectures. However, it's important to note that erythema nodosum can signal sarcoidosis in some types of cases. Remember that lacrimal gland involvement in sarcoidosis is kind of a clinical highlight. So if you see enlarged lacrimal glands in a patient, definitely be thinking about sarcoidosis. And of course, hilar lymphadenopathy, which are infiltrated with the sarcoidal granulomas. As I mentioned, lupus pernio, for beginners, this is confusing because of the word lupus. However, lupus pernio is really sarcoidosis involving the face, but the classic codochromes they're going to want you to know for boards are the papules and nodules on the nose of dark complected patients, at least knowing the differential diagnosis. If the question stem told you that you had sarcoidal granulomas here, the diagnosis would be lupus pernio. So here is a picture of a sarcoidal granuloma. It's well circumscribed, variably sized epithelioid histiocytes forming discrete naked granulomas with minimal lymphocytic infiltrate and little to no necrosis. We had a recent case of a pediatric patient that was presumed to be eczema, came in and was not responding to traditional treatment. Biopsy revealed sarcoidal granulomas, and it was a case of early onset pediatric sarcoidosis. There was apparently no family history, so it was most likely the first case within the family. These can be sporadic, they can be hereditary, and typically they're associated with a NOD2 mutation, which we will talk about. So here is a digital slide from the Cleveland Clinic Library highlighting sarcoidal granulomas. My attending at the University of Miami, one of my first days as a resident, showed me a glass slide of a patient that we had with sarcoidosis. And he said, they basically look like cannonballs in the dermis because they're so well defined and discrete. I never forgot that. And I think that was right when my interest in dermatopathology as a resident was solidified, which was really early on in residency. So when you see things like this that are so well defined and discrete, it becomes a really good teaching example. And so this is from the Cleveland Clinic archives, just a really great example of robust sarcoidosis. Zooming in on higher power there, just to show you the well-defined, discrete, well-defined, well-circumscribed nature of these sarcoidal granulomas, you don't see a lot of lymphocytes around them. So that's where the word naked granuloma comes from. And you're going to find these in sarcoidosis, which I mentioned and which we talked about, also Blau syndrome, which is a pediatric form of sarcoidosis. These patients often will have granulomatous inflammation of the skin, the uvea, as well as the joints. That's the classic triad of pediatric sarcoidosis. And you're going to want to look for the NOD2 mutation, also known as CAR15. We've had a case recently where that was indeed the case. Foreign body reactions. So anytime you have a foreign body reaction to silica, zirconium, beryllium, other foreign bodies, you can have development of sarcoidal granulomas. And in fact, if you do a biopsy and you find sarcoidal granulomas in reaction to a foreign body, you should actually try to rule out some type of systemic sarcoidosis, because this shows you that the patient has a predisposition to forming sarcoidal granulomas. Rarely you can see these in Michelson-Rosenthal syndrome, which is also known as cheilitis granulomatosa. You can see these in granulomatous rosacea, cutaneous Crohn's, tuberculoid leprosy, and so on. Sarcoidosis has inclusions, and so here are a list of different inclusions that you might be able to see in sarcoidosis. However, seeing these inclusions are non-specific, so it's not going to tell you, oh, this is sarcoidosis if you see. So asteroid bodies, which are star-shaped eosinophilic bodies within a giant cell. Phosphotungstic acid hematoxylin can mark these as well. They consist of collagen, and they're trapped between the epithelioid cells. Shaman bodies, on the other hand, are round or oval, laminated and calcified bodies. They're likely laminated residual lysosome bodies. So they stain more purple, and we'll show you some pictures of that because of the calcification on H&E. Hamazaki-Weissenberg are pale yellow-brown, rounded cigar-shaped structures, and they typically range from 1 to 15 microns, and they're present in a dumbbell configuration. The impression of budding yeast is what people typically think of when they see these Hamazaki-Weissenberg bodies. Typically, they're only found in sinusoids and lymph nodes, and they're not usually present in cutaneous disease, but it's important to know about them. Now, it's not specific because it can also be seen in granulomas of tuberculosis, leprosy, borreliosis, annular elastic giant cell granuloma, and sporotrichosis. So here you can see an asteroid body, another example, a shaman body, and another example. So the bottom right picture, the top left I like because it's really radiating out, and that's asteroid. And then your shaman body has these laminated rings of calcification. Again, these are not specific, but you may see them. And in fact, most cases of sarcoidosis that I've seen in real life, I never really see these very frequently. It's just more of a board's fodder type thing. And when you do see it, it's pretty fascinating to see. Another example of an asteroid body on the top left, a shaman body on the top right, a Hamazaki-Weissenberg on the bottom row here. And you can see that they look very similar to these budding yeast. And so if you had your differential including fungal, then that might be a little bit confusing. And so you really have to kind of put it together with the clinical scenario. As I said, it's a diagnosis of exclusion. And so, of course, if you do a biopsy and you see sarcoidal granulomas, you can say sarcoidal granulomatous dermatitis, and then say that exclusion of infection, exclusion of immunodeficiency, exclusion of foreign body reaction, all of those things will be important to exclude before you say the patient has sarcoidosis. It's also important to do internal investigation and make sure there's no multi-system involvement. So what's your differential diagnosis? You're going to think about silica granuloma. In that case, you'll see doubly refractory silica-rich particles. You're going to think about zirconium granuloma, which is also known as deodorant granuloma. You got to think about location of the lesions, the history. There's no birefringent material in zirconium granulomas. Beryllium granulomas, you're going to want to look for a history of industrial exposure or fluorescent light bulb exposure, and infectious. So, of course, tuberculosis, tuberculoid leprosy, things of that nature. Moving on to necrobiotic granulomas, this is where you have a collection of epithelioid histiocytes centered around alteration and degeneration of collagen. Necrobiotic granulomas include the blurring and loss of the definition of the collagen bundles itself, alteration in the normal staining, so you'll see increased basophilia and in ratio to the eosinophilia, and decreased connective tissue nuclei. You can see necrobiotic granulomas in these entities listed here. So granuloma annulare, necrobiosis lipoidica, necrobiotic xanthogranuloma, and rheumatoid nodule. So let's jump into granuloma annulare. It's one of my favorite histopathologic diagnoses. It's simple, yet it's just a very nice example every time you see it. So the clinical features are indurated plaques with no or minimal epidermal change. That's important, often with raised borders, and it's most common in the extremities, but it can occur anywhere from head to toe. The types include localized GA, generalized GA, which have an association with diabetes and HIV and AIDS and other things. Perforating GA, these often appear umbilicated. Deep GA, obviously it's in a deeper part of the skin, so subcutaneous nodules are often seen. And others such as papular GA, patch GA, actinic GA, drug-induced GA, and many others. A case report for every medical student out there. So here you can see granuloma annulare with the elevated rims. If you look closely, although the epidermis is shiny, it doesn't have much scale. So this is where you often see an elevated epidermis, but it's because of what's going on in the dermis below it. Of course, your differential diagnosis may include some partially treated tinea. It may include some other types of epidermal dermatitis, such as psoriasiform or spongiotic, eczematous, nummular dermatitis, things of that nature. So if you really don't know what it is, doing a biopsy on the elevated rim is going to allow the pathologist to look for granuloma annulare, and of course do fungal stains to rule out any type of partially treated fungal infection there. A lot of people forget that granuloma annulare can show up as papules too, so you don't always have the annulare part of GA. It can sometimes be papular. Here is a digital slide from the archives of the Cleveland Clinic, digital slides, and you can see palisading histiocytes around that necrobiotic collagen. So the epidermis looks really pretty unremarkable. You have a normal bascule stratum corneum. You have just a normal epidermis there, really no spongiosis or anything of that nature. The action is entirely in the dermis here. So this is a beautiful example of palisading histiocytes around necrobiotic collagen. If you go on higher power, you'll see increased mucin in between the collagen bundles. So those are all classic features for granuloma annulare. And I would bring your attention down here to the low power image where you can see the diffuse nature of the palisading histiocytes in the skin. Just another screenshot here to show you the increased mucin that you're going to see, as well as the increase in histiocytes with clear cytoplasm. It's kind of mixing together. So you see some areas of cellular rich and then cellular poor. These little punctate blue foci kind of on a string of fine blue material. This is more of your mucin in between the collagen bundles. And then you have your histiocytes with ovoid nuclei and pale to eosinophilic cytoplasm throughout. Here you see more mucin tracking up in here. And many examples of granuloma annulare, you don't actually need a mucin stain. You can see a lot of the mucin just on H&E. Here is a mucin stain just to show you that indeed there is a lot of mucin in this entity. This is probably some type of colloidal iron stain, which don't be confused, colloidal iron stains mucin. So granuloma annulare, we talked about the histopathologic patterns. You can have interstitial or infiltrative granuloma annulare, your traditional palisading granuloma annulare, your mixed interstitial and palisading, which I see a lot in real life, deep granuloma annulare, and perforating granuloma annulare. So here's an example of interstitial granuloma annulare. This is a little bit more nondescript, and if you're not looking carefully, it may be easily missed. So if the clinical is saying rule out, it could be anything, but if they are saying that they think it's granuloma annulare, you really need to make sure that there is not some infiltration in between the collagen bundles of these histiocytes. And so it can look from low power like you just have some superficial perivascular inflammation. But when you go on higher power, you'll be able to see the true interstitial histiocytic population, as illustrated well in this picture. Interstitial granuloma annulare, again, can be highlighted with the mucin to show you that you have an increase in the mucin there. Just another example of increased mucin here. Palisading granuloma annulare, that's the variant we're used to seeing, and we showed you an example of that. Perforating granuloma annulare, of course, is not going to be possible to make that diagnosis if you don't have a great biopsy. So over here to the edges, you're going to be able to say, well, that looks like a granuloma annulare. You've got interstitial histiocytic population, some areas of palisading around necrobiotic collagen. If you didn't have this normal piece over here, it would be impossible to call this perforating GA. But because we have juxtaposition here and putting it together with the clinical, if you've got this really exemplary reaction or pattern, inflammatory pattern rather, next to this perforating material with increased basophilic debris, you can think about perforating GA. Now, to be the devil's advocate, it would be difficult to completely rule out the fact that this could be some type of granulomatous inflammation occurring in the setting of a perforating disorder that was caused by something else. So close clinical correlation is going to be important, because if the patient has renal disease and they're more at risk of traditional reactive perforating collagenoses and other perforating disorders, calling it perforating GA may be a little bit trickier. And so just taking it into account. If the patient has really no other associations of other perforating disorders and you see this pattern, then you can think about perforating granuloma annulare. Again, it's more about reaction pattern identification more than anything else. Here you can just see more examples of the granuloma annulare reaction pattern around areas of necrobiosis. And this is a deeper area of perforating granuloma annulare. Deep granuloma annulare, again, is going to basically show the same pattern of inflammation, but it's going to be situated deep within the subcutaneous tissue. Differential diagnosis is definitely going to include a rheumatoid nodule. So you really have to think about clinical scenario, but typically deep granuloma annulare is found in young patients. It's found, oftentimes on the lower extremities or the foot. The patient's not going to necessarily have any other rheumatoid association. It's not clinically going to look like rheumatoid, but histopathologically, it may be easily confused. So get as much clinical information as you can. If it's a question on an exam, they're going to give you enough information to be able to at least statistically rank the likelihood that it's a deep granuloma annulare. Necrobiosis lipoidica, another favorite diagnosis of mine. The etiology is unknown. The clinical features, as shown in this beautiful picture here, illustrating this kind of yellowy plaque with erythematous borders. Some areas of ulceration are starting to occur. Epidemiology, 30 to 40% of these patients with necrobiosis lipoidica have diabetes, and that's why traditionally it was called necrobiosis lipoidica diabeticorum, and it still is known as that. However, when I sign it out histopathologically, I just sign it out as necrobiosis lipoidica. And that's because I'm not implying the patient has or does not have diabetes. You don't need to have diabetes to have this entity. Because 30 to 40% of patients with this entity likely will have diabetes, or have been shown to have diabetes, it means that the presence of necrobiosis lipoidica should make the primary care doctor or the dermatologist recommend ruling out diabetes if it's not known that they have it. But only 0.03 to 3% of patients with diabetes will ever have necrobiosis lipoidica diabeticorum. Just a larger clinical example of necrobiosis lipoidica here. And so with the necrobiosis lipoidica, it can get to a point that it's so extensive that you're going to have ulceration. And we've had some cases before where we had ulceration, and when we did the biopsy, we thought we were seeing features of necrobiosis lipoidica. But the problem is that once you have an ulcer, you have a lot of secondary inflammation. You can have secondary vasculitis coming in. Lots of other things can happen in chronic ulceration. So it's really difficult to make a diagnosis once it's gotten to the point of ulceration. But when you have intact skin like this is where you're going to get your classic necrobiosis lipoidica histology. And so what is the classic histopathology? In the epidermis, you're usually going to see a relatively normal epidermis, but depending on where you biopsy it, it's going to be atrophic. It might even be hyperkeratotic. So we don't rely on the epidermis to give us the answer. We rely on the dermis. And so in the dermis, you see granulomatous inflammation. Here, it takes on a cake-layering appearance, and I'll show you more examples of that. To come back to the text slide, we have the necrobiosis, which is in the name. You can see sclerosis, which you wouldn't be surprised based on the clinical that this would be somewhat sclerotic, even on histopathology. And the tear-like fashion of the layered histiocytes are going to give you this cake layering appearance, which is the buzzword. People likened it to a marble cake or a cake layering appearance. So if you see a rectangular punch and you see that cake layering appearance, as you can see in this picture from left to right or east to west, you have the lymphocytes, the histiocytes. In between, you have necrobiotic collagen, and you can understand why pathologists liken this to a cake layering appearance. So in dermatology, when we teach the residents, we want them to pick up on patterns, and this is one of the classic patterns that you're going to see. So a square biopsy sign suggesting some sclerosis, some necrobiosis, and then the left and right, east to west, lymphohistiocytic pattern. So you may see plasma cells, you may see cholesterol clefts. Again, you shouldn't rely on that to make the diagnosis. It's all about the clinical with the histopathologic to make that correlation. It can be difficult if all of your answer choices include other types of granulomatous inflammation. So you really are going to be hoping to have some clinical hint. The best questions are going to give you things that it definitely wouldn't be confused with. So this is a classic for NL, but if they were giving you, palisading neutrophilic and granulomatous dermatitis, for example, you'd want to go in and make sure you don't have a ton of neutrophils. So that would help you choose necrobiosis lipoidica as the best answer. You don't see perfect palisading here. It's more of an east to west. So I would not favor a granuloma annularia if I didn't have any clinical information. Also, there are some really dense areas of histiocytes that are collecting, and it doesn't have that classic interstitial granuloma annulare pattern. Here you can really appreciate the east to west orientation in the areas of necrobiotic collagen. Moving on to necrobiotic xanthogranuloma. These are clinically associated with large yellow indurated plaques. They often are periorbital. They can have telangiectasia and ulceration. They can often even be confused for sebaceous hyperplasia or basal cell carcinoma because their appearance on the face and then the yellow color makes people think sebaceous. The rolled border appearance makes people think of basal cell carcinoma. So you often have periproteinemia in 80%, paraproteinemia in 80% of cases, and it's often associated with a monoclonal IgG kappa light chain. So you can think about necrobiotic xanthogranuloma being most likely associated with kappa. In contrast, other entities associated with lambda light chains include things like scleromyxedema. So keep that in mind as a high yield factoid. Course is usually chronic in necrobiotic xanthogranuloma, and it's often progressive. Systemic manifestations include giant cell myocarditis, hepatosplenomegaly, and lymphadenopathy. Good clinical examples here of NXG in the periorbital regions, some areas behind the ear, as well as just other parts of the body showing you that yellow papular appearance with the surrounding erythema. So what is the histopathology of necrobiotic xanthogranuloma? You're going to want to look for palisading necrobiotic granulomas with extensive necrobiosis. So again, it's in the name. You'll want to identify foamy macrophages, Teuton giant cells, plasma cells, maybe even some follicles forming within the tissue, some reactive B-cell lymphoid hyperplasia, and cholesterol clefts. So the best examples for a test are going to give you enough hints that you're going to be able to make that diagnosis. So I feel most of the examples show a giant cell rich inflammatory pattern with some cholesterol clefts and some necrobiosis. And so that allows me to put that on the top of the most likely correct answer choice. If you didn't have clinical. Now, if you had clinical and you had this, then it's going to be pretty easy to get the answer correct. Just more examples of the diffuse infiltration of the granulomatous inflammation and the necrobiotic collagen on low power. It even extends down into the fat here. So you almost have like a lobular paniculitis reaction. And then these giant cells are pretty numerous. The Teuton giant cells are pretty numerous throughout. Some cholesterol clefts within necrobiotic xanthogranuloma, just a great example of those. Moving on to rheumatoid nodule, these are usually deep-seated firm masses, patients with rheumatoid arthritis. Rheumatoid factor is usually high in these patients. Extensor prominences as far as the clinical location goes. Now, if the patient does not have rheumatoid arthritis, and you still have this presentation, it can be a pseudo rheumatoid nodule. Tests like to ask about accelerated rheumatoid nodulosis, which is a rapid appearance of many small rheumatoid nodules in some patients that are treated with methotrexate. So here's a nice clinical example of a rheumatoid nodule, a very deep-seated nodule on the elbow of a patient that probably has rheumatoid arthritis. On histopathology, it's in the subcutis and the deep dermis, but it looks different than a deep granuloma annulare to me because I often see these very eosinophilic rich cores that are surrounded by those histiocytes. So when you see that necrobiotic granuloma with a large central zone of fibrinoid degeneration that stains very eosinophilic red, minimal to absent mucin in the surrounding of these cores, these fibrinoid degeneration cores, by these palisading histiocytes, and it's in the proper location in the skin, the deep dermis of the subcutis, and you don't have any other clinical information, then I would rank rheumatoid nodule at the top. You can see foreign body giant cells in about half of the cases. Now, from low power, you should be thinking that your differential diagnosis is not only inflammatory, but neoplastic as well. So unfortunately, epithelioid sarcomas can present looking very similar to this on low power. So you'll have to go on higher power on your exam and make sure you're not dealing with very pleomorphic, mitotic activity-based neoplasm, because there have been some examples of such things that are very testable, but also it's important because in real life, if you have a patient that has a deep-seated growing nodule and they don't have any history of rheumatoid and it looks like a rheumatoid nodule on low power, then you better go on high power and be looking for the evidence of atypical epithelioid cells, which might represent an epithelioid sarcoma. And then at that point, you would do testing for keratins to look and see if there's keratin expression to help support an epithelioid sarcoma, as well as doing an INI1, which is going to be lost in more than 90% of epithelioid sarcomas. Just another example here of rheumatoid nodule. Moving on to tuberculoid granulomas, these are collections of epithelioid histiocytes and giant cells surrounded by a substantial rim of lymphocytes. So in that very, very first picture I showed of the granuloma, that's why I said it's probably a tuberculoid granuloma, because you had that substantial rim of lymphocytes. They're usually less circumscribed and they're more confluent than sarcoidal granulomas, but you may or may not have caseation necrosis. And so that's where this necrotizing versus non-necrotizing comes in. So in necrotizing, you'll think about the tuberculosis more so. But if you see it, it doesn't necessarily mean it is tuberculosis, because necrotizing is a nonspecific trait. However, it does push you towards that direction. Non-necrotizing, you can think of this entire list here. So atypical mycobacterial infections, leprosy, late syphilis, leishmaniasis, rosacea, perioral dermatitis, lupus miliaris, disseminatus fasciae, and Crohn's disease. Jumping into granulomatous rosacea, I see this a lot in our clinic because we get lots of biopsies that reveal granulomatous inflammation around hair follicles and demodex folliculitis. And clinically, the impression was some type of rosacea. And so it all fits to support the diagnosis of granulomatous rosacea. And people forget that you can actually have such severe rosacea, and it's not necessarily acne, but it's more of a, it looks a lot like acne, but it's slightly different in the way it presents clinically and histopathologically. Often we see our patients above 30 years old who have these reactions on the face. This is a very robust granulomatous rosacea clinical example. As you can see, it doesn't quite look like acne. There's something different about it. These papules are a little bit smaller. They're a little bit more diffuse. They're on the top of the nose, on the seborrheic areas, down onto the chin. Acne and rosacea definitely share a lot in common, but there's just something a little bit different about this. Clinically, the way it appears, more monomorphic in many cases. And so this is your granulomatous rosacea. Histopathology, you're going to see the vascular dilatation or telangiectasia of the upper and middermal vessels. You're going to want to look for perivascular and perifollicular lymphohistiocytic inflammation, follicular plugging, shoulder perikeratosis, which are buzz phrases for seborrheic dermatitis, occasional plasma cells, which are often reactive in nature on the head and neck of patients. You may see granulomatous infiltrates in about 10% of the cases. These can mimic mycobacterial infections with epithelioid histiocytes forming a tuberculoid pattern. You may see foreign body granulomas developing around debris and organisms, and of course, Demodex mites. And shout out to the Cleveland Clinic Fellowship alumni, as we are all members of the Demodex Society. So here on the top right, you can see a really beautiful example of a Demodex mite within the follicular ostia and then surrounding lymphohistiocytic inflammation in the follicle. So this is a classic series of images to give you a good learning example of granulomatous rosacea. On the bottom left here, you have the small panel that shows you dilated vessels. And then on the upper left, you just see this low power biopsy that shows scattered, dense granulomatous inflammation. But seeing the Demodex here definitely signals that there's probably some rosacea component going on. And as one of my mentors in Miami said, a joke that he said, everybody has a Demodex in their face, except for me. I'm the only person that doesn't, but everyone else does. And so we all tend to think that we do not have Demodex mites, but they're super common. And if patients with rosacea have the reaction pattern, they probably have a higher load of Demodex mites. And so giving them treatments such as topical ivermectin to kill off those Demodex mites has been shown to be very effective. Granulomatous rosacea example here with just more of this kind of granuloma appearance with intermixed peripheral lymphocytes. Lupus miliaris disseminatus fasciae, another one of my favorite diagnoses because of the histopathology. Historically, it's also been known as acne agnata. The clinical features include papules and coalescing in the plaques in some cases, located around the eyelids and upper lip. Typically, there's a lacking of the background of erythema and telangiectasia of rosacea. So there's something different about this, and it strikes you as it's not quite acne, it's not quite rosacea. Again, the picture on the left, you might be thinking of a granulomatous rosacea. These kind of monomorphic papules and nodules coalescing into plaques. However, this looks even more robust. However, without a biopsy, it's going to be really difficult to say what's going on. So lupus miliaris disseminatus fasciae, the classic histopathology is going to contain central kind of caseous necrosis, very eosinophilic rich necrotic zone surrounded by aggregates of epithelioid histiocytes and occasionally multinucleated giant cells with sparse peripheral lymphocytes. And this is a favorite for examinations and things like that, I'm imagining, because it is such a recognizable entity. And it's definitely one that is unique into its own class when you see this central necrosis here. And that's why people call it lupus miliaris disseminatus fasciae, because it looks like it's some type of caseous necrosis that you might see in tuberculosis. So if you have this clinical here, this histopathology, obviously you're going to want to make sure you're not dealing with a tuberculosis and doing a phyte stain, doing mycobacterial Zeal-Nielsen stain to try to pick up and make sure you don't have any mycobacterial infection here, even doing some fungal stains, making sure you don't have a fungal infection. That's all very important too. But when you're left with ruling out infection and you have this, then the best diagnosis is going to be lupus miliaris disseminatus fasciae. Moving on to foreign body granulomas. So the most common foreign body giant cell reactions that I see are from ruptured epidermal inclusion cysts. These can come from really small hair shafts and just maybe even within the setting of folliculitis, but they can mostly come from large cysts that have been ruptured by the patient themselves, trying to be Dr. Pimple Popper at home. And so they'll come in and they'll have partially ruptured cysts. However, sometimes in in a surgical excision of these, the cyst may have been acutely ruptured. In that sense, you may really only find areas where the sac was broken. But if the rupture occurred pretty, I would say like maybe a day or two before the surgery, you're going to have more neutrophilic rich inflammation. If it's been chronically ruptured, you're going to have more giant cell inflammatory reactions, as well as absorption of cholesterol clefts and keratin granulomas. So it really all depends on the time relationship and when that rupture occurred. Extrinsic foreign body granulomas, these can happen in the setting of organic causes such as cactus bristles or wood splinters, insect mouth parts, and inorganic causes such as suture material, talc, starch, tattoo material, pencil lead, silicone, splinter, you name it. Here's an example of a keratin granulomatous reaction. So these fine, thin eosinophilic strands of keratin surrounded by the granulomatous inflammation. This is a great example of a keratin granuloma. Again, these are known as foreign body granulomas. So you can have on the left a reaction to the keratin, on the right, maybe even some braided suture material, I think is what we have here. Here's an example of granulomatous inflammation around a splinter. Splinter's located on the top right. You can have granulomatous reactions to tattoo ink and particles. And here's a screenshot from the video that I made on the tick bite that we captured in our clinic. The patient had some type of reaction. I think we saw the top half of the tick. We did a biopsy and we captured the mouth part retained within the dermis. And this is actually an example of a minimal foreign body reaction, but you still have embedded tick parts within the dermis. And then in this particular case, we actually embedded the tick itself. And so you can see the larger body of the tick. And I would refer you to watch this tick bite video because I spent 3.5 minutes going over this tick within the skin. It was a nice example of retained tick parts. So we often can see silicone granulomas in places where patients are getting silicone injections, sometimes with cosmetic providers that are not licensed or doing things underground. And so silicone granulomas, unfortunately, are found when patients are having these robust foreign body granulomatous reactions to where they had the silicone injected. Either oftentimes we'll see them in the breast area, the buttocks area. You can have rupturing of breast implants, which can lead to silicone granulomas. The histopathology is likened to a Swiss cheese appearance due to the numerous ovoid and round cavities. That's known as a periphenoma. You'll see variable numbers of foreign body giant cells and macrophages, and they have foamy appearance. So here's your Swiss cheese example of the silicone granuloma. These droplets of silicone within the tissue and surrounding lymphohistiocytic and granulomatous inflammation with multinucleated giant cells. Moving on to an entity called annular elastolytic giant cell granuloma. So in sun-exposed areas, you have these annular plaques, oftentimes on the back, the upper shoulders, as shown in the bottom panel. On pathology, you'll see a nodular diffuse granulomatous infiltration of lymphocytes, histiocytes, and many multinucleated giant cells containing asteroid bodies and elastic tissue. And that's known as elastic fiber phagocytosis. So if you do a Verhoef van Giesen stain to highlight the elastic fibers, you may see that fragments of elastic fibers are located within the giant cells themselves. And that helps to clinch the diagnosis along with the clinical information. In contrast to the other types of granulomatous inflammatory patterns, you will not see a lot of necrobiosis and you won't see a lot of mucin. You won't see as much palisading as granuloma annulare in traditional GA examples. It's been taught traditionally that there are 3 zones in well-developed lesions. So you'll have a zone of solar elastosis, you'll have a zone of granuloma with elastic fiber phagocytosis, and you'll have a zone of absent elastic fibers. More examples of the elastophagocytosis that you'll see the giant cells engulfing the elastotic fibers. On the left with an H&E stain, and on the right you can see Vera van Giesen staining the black fibers here. Another example of the annular elastolytic giant cell granuloma, just more examples to see. Of course, without any clinical information, it wouldn't be unreasonable to think about some type of interstitial GA or granuloma annulare, but again, you're not going to see as much of the classic mucin within the histologic sections, and the clinical will be quite different as well. Many times these will be signed out as granulomatous interstitial and palissading granulomatous dermatitis. And then if you have evidence of the engulfing of the elastic fibers, then you can mention that the top differential includes elastolytic annular or annular elastolytic giant cell granuloma of O'Brien. All right, so we're kind of shifting gears now. We're moving on to histiocytic disorders, which will include xanthomas, including juvenile xanthogranulomas, multicentric reticulohistiocytosis, and Langerhans cell histiocytosis. So before we jump into what histiocytic disorders are, we need to talk about the definition. So what are histiocytic disorders? These are lesions or processes derived from Langerhans cells or macrophages. So you can have Langerhans cell histiocytosis, you can have non-Langerhans cell histiocytosis. And what's the difference between a Langerhans cell and a macrophage? So Langerhans cells are a special cell type that are present in the skin, and it's a dendritic cell. The primary function of the cell is to present antigens. So it's an antigen presenting cell. Macrophages are histiocytes, and they also present antigens. So they are also antigen presenting cells, but that's more of a secondary function. Langerhans cells are defined by CD1A expression as well as S100 expression and Langerin or CD207 expression, whereas macrophages are more defined by general macrophage / histiocyte markers, CD68, CD163, etc. Now, it's still an ongoing process to further define subtypes of Langerhans cells and macrophages or histiocytes. And the more studies that are done, the more new immunohistochemical studies that are done, and the more clinical correlation that is done, we may find that there's more overlap than we thought, and there may also be a lot more room for splitting different entities into further subcategorization. So just keep in mind that this is a general concept, but it's most useful to see examples and how this fits into disease processes so you can develop a framework to understand the different types of histiocytes. So jumping into xanthoma is probably the easiest to understand because xanthoma makes you think of lipid-filled. And so lipid-filled histiocytes are the most prominent, and you'll see clinical variations that are considered xanthomas, but based on the clinical, they may be a different subtype. But histopathologically, the core universal theme is that you're going to have these lipid-filled histiocytes or lipophages even. So you have clinical variants of this, and we'll talk about some of those. It's not a clonal disorder, so these are not considered neoplastic. If you were to do immunohistochemistry on these cells, you would find that they're CD68 positive as well as CD163 positive. CD163 is thought to be a little bit more specific than CD68 when it comes to marking histiocytes. Oil red O is a special stain that will actually highlight the lipid content. So it's positive for that. And it's negative for CD1A. Again, why is it negative for CD1A? Because it's not a Langerhans cell process. It's just a general macrophage slash histiocyte process. So a low, medium, and high power view of the xanthoma here. You can just see these lipid-rich histiocytes. Xanthoma clinical subtypes include eruptive xanthoma, tendinous xanthoma, tuberous xanthoma, planar xanthoma. You see this in xanthelasma as well around the eyes, and verruciform xanthoma. Jumping into eruptive xanthoma, clinically, you'll have yellow papules with or without a red halo. They're often heritic. They can show up on the buttocks, the shoulders, the extensor limbs, fossa, the axilla, lips, eyelids, ears. They show up in crops in the setting of hypertriglyceridemia and hyperchylomicronemia. These can be secondary to diabetes, drug intakes, alcohol, nephrotic syndrome, or hypothyroidism. To biopsy these, they mostly contain triglyceride. And it's important that a lot of the lipid content will even be outside of the cell. And so that can help give you a hint on if you just had the histopathology, eruptive xanthoma versus the general xanthoma that I showed you in the previous example. Tendinous xanthomas slowly enlarge, and they're subcutaneous masses of the tendons, obviously, often show up on the hands, knees, elbows, and Achilles region in the setting of familial hypercholesterolemia, which results from an LDL receptor deficiency. Patients usually have severe cardiovascular disease, coronary artery disease. These can mimic gouty tophi or rheumatoid nodules, and they can coexist with tuberous xanthomas and xantholasma. Tuberous xanthomas are firm yellow-red papules and nodules on the buttocks, the extensor knees, and elbows, usually associated with dis-beta lipoproteinemia type 3, and also associated with homozygous familial hypercholesterolemia, cerebrotendinous xanthomatosis, beta cytosterolemia, and type 4 hyperlipoproteinemia. The clinical differential includes erythema elevatum diutinum and cholesterodic dermatofibroma. Tuberous xanthomas in the early stage consist a lot more of the foam cells, but in the later stages become more fibrotic, as shown in these images from the McKee textbook. Verruciform xanthoma is another one of my favorite diagnoses. They're extremely rare, but I've seen quite a few in my early career here. They're not associated with human papillomavirus, so they are verruciform, but they are not viral driven as far as we know. They're warty exophytic epidermal proliferations with foamy cells within the papillary dermis. So that's going to be the key to making the diagnosis. Here's an example. They often show up on the tongue. And you can see in the papillary dermis the presence of these foamy histiocytes. On the outer edge in between, you have these V-shaped, almost parakeratotic regions, and that's also a classic feature of verruciform xanthoma. Another example of the foamy histiocytes in the papillary dermis and this V-shaped parakeratosis. Moving on to juvenile xanthogranuloma. So these are on infants and toddlers. They show solitary papules, yellow, orange, reddish brown, flesh-colored papules and nodules. On histopathology, you have intradermal proliferation. The exact cell origin is still not completely understood, but you have tons of histiocytes with eosinophilic vacuolated cytoplasm. It mixed with inflammation of various types of cells, including eosinophils. Later, you have more xanthoma cell presence with spindle cells and the Teuton type giant cells. So for your test taking purposes, I'd imagine that they would want to show you Teuton rich giant cell JXG. However, in real life, they don't always have the Teuton type giant cells. So in the early lesions, you may not have as many. So you have to take into account the clinical presentation and ruling out all the other serious stuff. So doing a CD1A on this to make sure you're not dealing with some weird Langerhans cell histiocytosis is going to be advised. Speaking of that, let's move on to the Langerhans cell histiocytoses. So here is a presentation of a young patient that has these papules. In this picture, it's kind of in the diaper region, so where the diaper would actually kind of buckle around the waist, and then you have these intertriginous, very thin plaques, but very inflamed as well. And so clinically, our young patients often present with many different types of dermatoses that can look exactly like this and not be Langerhans cell histiocytosis. But I found that patients with deeper red macules that almost look like there's a vasculitic process happening, probably due to the destruction of small blood vessels within the space due to the clonal proliferation of Langerhans cells, is kind of a key tip off to that there's probably something else going on. Additionally, being refractory to any other type of treatment, whether it be treatment of presumed fungal infection in the diaper region, or presumed contact dermatitis in the diaper region, presumed eczema or seborrheic dermatitis, and they're not getting better, then the threshold is always low clinically to um, try to rule out Langerhans cell histiocytosis, because early on in life, this can be rapidly fatal. Um, Many times our older patients will present and they've kind of passed the point of the traditional or classic peak activity of letter Sui disease or acute generalized Langerhans cell histiocytosis. So many times we're looking for Langerhans cell histiocytosis, and we may not, we never prove that it is, and then the patient gets better. And so that's always the best scenario for the patient, is that it's not Langerhans cell histiocytosis. But the problem is that it's rare, but it does happen. And so um, many times rashes are biopsied in our young patients to make sure we're not dealing with Langerhans cell histiocytosis. And we'll talk about how this presents histopathologically. Another example of involvement on the head and the scalp region here, and you can really see these deep red, almost vasculitis-like macules and papules that are occurring. It looks worse than seborrheic dermatitis. It looks worse than a fungal infection, but this is a more evolved disease case here. And so you can see what it can look like in the distribution clinically, which is important because you really have to, if you're really worried about Langerhans cell histiocytosis, you have to put that on the requisition, and the pathologist will have to work with the clinician to maybe do some further workup and see, is there any other on deeper sections or more additional stains we can do to try to make sure we're not dealing with the Langerhans cell histiocytosis. It's important to have a strong communication between the clinicians and the pathologist when there is concern for it, and admitting sometimes that we cannot rule it out based on the skin biopsy alone, and that clinical correlation with other systemic findings will be important to clinch the diagnosis. So what do you see on Langerhans cell histiocytosis? So in more subtle examples, you're not going to see this, but in the examples where you have more dermal proliferation of these neoplastic cells, you'll see a classic sheet-like growth pattern of histiocytic cells. They typically take on a uniform or clonal appearance. They're often pale. They have infolded or reniform vesicular nuclei, plus or minus longitudinal grooves within the nuclei, and mitotic activity, but usually not a ton of mitotic activity. Now, it's classically taught, and you should know, that the electron microscopy would show Birbeck granules, and these are positive for CD207, which is known as Langerin. So Langerin is a very specific marker for Langerhans cell histiocytosis. It's in the name. Just be aware that CD207 is the other name, and they may put that on an exam expecting you to know that. So here is an example of that sheet-like growth pattern, these ovoid monomorphic clonal looking cells. They have some reniform nuclei in some areas. You see this kind of destruction of vessels with extravasated red blood cells, extravasated erythrocytes here underneath the crust. And so this is where you're getting that deep, almost purpuric macule, and maybe in some cases palpable purpuric papules because of that intense infiltration. I find that this also helps me if I'm dealing with just maybe like an eczematous process in a young patient. If I don't see this robust extravasated erythrocyte reaction, then I tend to think, okay, it's probably not an aggressive proliferation of neoplastic cells. However, if the clinician is worried about Langerhans cell histiocytosis, I always do a CD1A and an S100 because I want to define the distribution of Langerhans cells. And if I think that there's more than what needs to be there, I'm going to make it in my comment that I can't rule out an evolving process, and that biopsy of additional lesions or more progressed lesions should be considered, because sometimes you can't prove it in just one skin punch biopsy, depending on what you're looking at. Also, making sure that you remind the clinicians that if there isn't a pretty decent amount of epidermal Langerhans cells, that you need to go back to the clinical scenario and maybe do some bone scans, do some basic labs, look for evidence of other organ damage to make sure that you're not dealing with um, more generalized systemic involvement. Higher definition of the tennis rackets here. So the Burbeck granules. So anytime you see this tennis racket Burbeck granule on electron microscopy, they're wanting you to think about Langerhans cell. We talked about the immunohistochemistry already several times, but CD1A, S100, Langerhans, also known as CD207, are the classics you should know. Traditionally, it's been shown that peanut lectin, ATPase, alpha D manosidase, vimentin, CD45, and gold chloride are also markers of Langerhans cells. Some different subtypes of Langerhans cell histiocytosis. So you have generalized acute Langerhans cell histiocytosis, traditionally known as Lederer-Sui disease. It occurs in children less than 2 years old. It has a poor prognosis, unfortunately. On the scan, you have 1 to 2 millimeter discrete seborrheic papules. And again, it can look like seborrheic dermatitis clinically. It can look like seborrheic dermatitis on histopathology as well, depending on the sample. It involves the scalp and the flexures. You see petechiae and purpura, which to me are more indicative of potentially an LCH versus a seborrheic dermatitis, because usually you're not going to see a lot of petechiae and purpura in the presence of just your run-of-the-mill seborrheic dermatitis. You're going to see lots of inflammation, but typically that deep purple vasculitic appearance, you're not going to necessarily see that in seborrheic dermatitis. Scale crust and fissures you can see in a lot of things clinically. So even sebderm or diaper dermatitis or atopic dermatitis, contact dermatitis on top of atopic dermatitis. So that's not really that helpful clinically, but you will see it. Multi-system disease. So if there's any clinical concern for LCH and the pathology is not definitive, that's when I recommend doing a multi-system evaluation. So bone, painful osteocytic or osteolytic lesions, spleen, nodes, marrow, liver, and lung can all be involved. These patients often have fever, weight loss, lymphadenopathy, and cytopenias. So they're very sick. If a patient comes in and just has a rash and there's nothing else going on, then it's probably not Langerhans cell histiocytosis. Multifocal chronic Langerhans cell histiocytosis, also known as Hand-Schuller-Christian disease. Kids under 5 years are more affected than teens, which are more affected than adults, which are more affected than the elderly. It's a more chronic course with less mortality, thankfully, than acute generalized Langerhans cell histiocytosis. The triad includes diabetes insipidus in up to 20% of patients. Lesions of the pituitary or the hypothalamus cause the diabetes insipidus. They also can have osteolytic bone lesions in the area of mastoid or temporal bones, which leads to chronic otitis externa and exophthalmos. Fewer skin lesions are present in multifocal chronic LCH as compared to acute generalized LCH, but you do have the same distribution. You can see erythematous scaly papules, which again is the most nonspecific thing in dermatology, and in the head, neck, oral, and anogenital regions. So again, if a patient just has a skin rash and they don't have any diabetes insipidus or osteolytic bone lesions, they probably don't have multifocal chronic LCH. But if the clinician is concerned and the patient has other clinical findings that are indicative that there's something more going on, then deeper investigation has to be performed. Focal chronic Langerhans cell histiocytosis is also known as eosinophilic granuloma. This occurs in older children, 7 to 12 years of age. It does have, thankfully, a good prognosis, and they can spontaneously regress. They may present with bone fracture, and that's because you can have solitary lesions of the bone. The cranium is the number one area that's affected usually, but these can also develop in the lung, the lymph node, the brain, the skin and oral mucosa, which is rare. And on that note, it is rare to have skin lesions. You're going to find extensive crusted papules in the seborrheic distribution. and if it is affected, and you may find solitary or even multiple crusted nodules, but typically it's one nodule. Other LCH variants include congenital self-healing Langerhans cell histiocytosis, also known as congenital self-healing reticulohistiocytosis, Hashimoto-Pritzker disease. This is a little bit controversial because it's possible that this entity is actually just a reaction pattern to another type of dermatosis that is happening on the patient's skin. And remember, Langerhans cell histiocytes, the whole purpose is an antigen presenting cell. So if there is some type of infection on the skin, seborrheic dermatitis, eczema, there's a impetiginization, there is yeast or candida on the skin, the Langerhans cells are going to go after that, because the whole point is that they're going to be absorbing these antigens and presenting it to the immune system. And so it's not surprising that there are some entities called congenital self-healing Langerhans cell histiocytosis where a biopsy was done and there appeared to be some increase in Langerhans cells, but then the patient just got better. And it may have just been that the Langerhans cells themselves were just a reaction pattern to whatever process was going on. So it's a little bit controversial. Nevertheless, diagnosing a young child with Langerhans cell histiocytosis, it puts a label on the patient that is pretty serious. And so anytime that label is put on a diagnosis of the patient and they get better and it just self-heals, well, then that's great for the patient. But keep in mind, not all Langerhans cell histiocytoses are created equally. If you do stains on a rash in a child for CD1A, you will detect Langerhans cells in the skin, that because they normally have Langerhans cells as well. So really putting everything into clinical context is going to be crucial when trying to decide if you're dealing with a more serious Langerhans cell histiocytosis. So these are present at birth. They regress in about 3 to 4 months. They're widespread red, blue, brown macules, papules, and nodules. They can be a fraction of a millimeter. They can be over a centimeter. They can be ulcerated in some cases, solitary nodules in some cases, and they essentially have identical histology to other forms of Langerhans cell histiocytosis. However, if it's restricted to the epidermis and superficial dermis, that's going to typically be the most common presentation. If it's more robust, filling up the dermis, well, then that's going to be more worrisome. And, the more Langerhans cells that are present, the more likely that you're probably having some type of histiocytic reaction, histiocytic proliferation. Separating out reactive versus clonal proliferation is key. And so, whereas reactive histiocytosis should get better, a true neoplastic process is not going to get better that easily. So kind of comparing some of these side by side, acute generalized Langerhans cell histiocytosis, we don't have the Hashimoto-Pritzker on the screen here, but going back to the previous types of LCH that we talked about, letter Sui, you're going to see that mostly in the upper dermis. You're going to see loose aggregates of cells, microabscesses of Langerhans cells, which can be seen in contact dermatitis as well. So Langerhans cell microabscesses can be present in an atopic dermatitis with secondary contact dermatitis. So that is a Langerhans cell microabscess is not specific for LCH, but it does say that you can't really exclude it, and close, careful clinical follow-up is recommended. You may or may not have red blood cells, giant cells, xanthomas, may or may not have many eosinophils. So don't rely on the other cell types for this, mainly just focus on Langerhans cell. Multifocal chronic Langerhans cell, like we said, you'll see dense dermal infiltrate. You can see more eosinophils. You can see frequent giant cells as well, but you don't have, typically, you don't have a lot of xanthoma cells. Again, typical. But in my opinion, again, if you've got destruction of multiple cells, the cholesterol will leak out and be absorbed by other histiocytes. So in my opinion, you can see pretty much any cell type within the multifocal chronic LCH as well. The most important thing is the dense dermal infiltration of Langerhans cells. And then solitary LCH, again, is going to look very similar to the dermal-based multifocal chronic LCH. You might have more eosinophils, and again, that's why it's called eosinophilic granuloma, but the clinical is going to be much different. And so you'll find that solitary lesion. Cranium is the number one affected area in the bone. So here's a picture of a process that's not, we're shifting gears and we're showing some papules on the dorsal hand. So what do you think about? You see these beads of erythematous papules around the proximal nail fold and on top of the entire hand. This appearance here should make you think of a multicentric reticulohistiocytosis. So this is a process that is on a disease spectrum. So cutaneous reticulohistiocytosis, it has early stages and later stages. So in the early stage, you're going to look for histiocytes and lymphocytes. Each one of those will be kind of sitting on a punched out lacuna, as you can see here, with two-tone cytoplasm. So you've got some areas of light pink punctate staining, and then this kind of transition to a darker pink to purple stain. And so that's your two-toned cytoplasm that you'll often see in reticulohistiocytomas. Later on, you'll get more numerous multinucleated giant cells. And so you may see a theme. The early lesions don't have as many giant cells, multinucleated giant cells, and then the later has more multinucleated giant cells. Here, we're showing examples of just kind of the later, it's probably a transition from early to late, but you have plenty of giant cells here. On the first picture, you have more organized rimming of the punched out appearance. And then in the later picture here, you have just kind of more of a mixture of diffuse spatial organization of the nuclei itself. But the key is that you're still going to have the retention of the ground glass two-tone cytoplasm. So if you go on high power, you'll see that it looks like ground glass. And that's where this phrase ground glass two-tone cytoplasm comes in. Here's a picture of another higher power just to show you that two-toned appearance of the cytoplasm, the broken ground glass. And we're just briefly highlighting this disease from a pathologic entity, but I will say that it's important to rule out some systemic malignancy if you have presence of reticulohistiocytosis in a patient. And we're going to finish with Rosai-Dorfman disease. So this is also known as sinus histiocytosis with massive lymphadenopathy. It's rare and it's usually benign and self-limiting. However, not every Rosai-Dorfman disease patient is created equal. And in fact, some patients have more of the massive painless bilateral cervical lymphadenopathy, which is what gives it the other name of sinus histiocytosis with massive lymphadenopathy. You can have cutaneous only Rosai-Dorfman disease as well, but the more serious systemic involvement is associated with pyrexia, night sweats, neutrophilia, increase in ESR, and polyclonal hyperglobulinemia. Less than 10% of these patients actually have cutaneous lesions, but in dermatology, 100% of our patients with skin involvement are going to be our patients, and we're going to be doing those biopsies. And so in dermatology, we see what appears to be higher than 10%, obviously, because we see these patients when they have skin lesions. They show up as solitary, clustered, or diffuse red-brown papulonodules. You can have interesting presentations that look like rosacea, granuloma annulare, or even vasculitis. The number one site affected is the face, so the eyelids and the malar cheeks. Again, differential diagnosis is quite large for papules and nodules on the face in our patients, as you can see in the diseases that we've discussed today. So on low power, if you see something that looks like a lymph node in the skin, you should be thinking about Rosai-Dorfman disease. Many times you can have reactive lymphoid hyperplasia that can look like this as well. But if you go on higher power, you'll see that there's some larger histiocytes that appear to be engulfing these lymphocytes, and that's called imperipolesis. So if you see what looks to be like lymph nodes in the skin, maybe a little bit of a in the lymph node itself, you'll actually see capsular fibrosis and dilated sinuses with many histiocytes. But in the skin itself, you may actually see so much lymphoid infiltration that it looks like a lymph node. The cytology of the histiocytes, if you go in high power, you'll be able to appreciate abundant pale staining eosinophilic cytoplasm, large vesicular nuclei, plus or minus small nucleoli. You'll see the lymphocytes within the cytoplasm itself. And peripoiesis is the buzzword you should know. If you do immunohistochemistry on these histiocytes, they will diffusely highlight with S100. And it's a nice picture because you'll have this brown histiocytic outline and then these empty holes where the blue lymphocytes are sitting within. So it's really cool to see on S100 staining. So the skin lesions are going to be dermal and subcutaneous, similar to lymph node histology, where you've got this nodular pattern. You will most often not have a Grin zone. A Grin zone you typically think of being present in several entities, but especially B-cell lymphomas. And you'll have a mixture of reactive inflammatory cells. The last big pearl for you all here for the beginners is to remember that this is a non-Langerhans cell histiocytosis, so it's CD1A negative, but it is S100 positive and CD68 positive. So remember that CD1A is negative in this entity, but S100 is positive in this entity. And that's the only thing that it really kind of shares in common with Langerhans cell histiocytosis, that it is S100 positive, just like a Langerhans cell histiocytosis would be as well. But LCH would be CD1A positive as well. And then your CD68 is your general histiocyte marker. So if you have this histopathologic picture, remember S100 is your stain that you're going to want to do to highlight these histiocytes. So that is it for the basic overview of histiocytic diseases. This is just the beginning for people. And so just having a familiarity of how the different diseases can present are important. And being able to look at many examples and familiarizing yourself with the way that they present, not just clinically, but histopathologically, will help you be able to choose the correct answer on your exam. But if you do go into derm path, it'll help you make the correct diagnosis.